Okay, hello. Sorry, I had to reboot my computer. It was frozen. So it's been giving me fits since last night. So hopefully this will go well. Just type here when you're here. So just type here for now. And then we'll get started. So yeah, sorry. Okay, I'll be right back. Hey, AJ. Hey, AJ. AJ, come say hi to everybody. Come here. Oh. I mean, I haven't seen everybody in a while. Show how big you are. He's like, I'm a big boy now. 25 pounds. Who is it? Look at everybody. AJ, do you see? Oops. He's like, I don't want to be on my lap. Can you say hi? We're going to talk about anesthesia. How do we anesthetize you? What drugs is he sensitive to? What drugs are you sensitive to, huh? Oh, don't fall off my lap, you big boy. Want to stay on my lap? You chew my pens? Don't eat the mouse. Don't eat the mouse. Yeah, I've been posting lots of pictures because they're being super cute. They sleep together. They wrestle. I let them out, Gabe. So yes, you'll see lots. If you follow me on Facebook, you'll see lots of pictures of these guys. Say hi. It's nap time, baby. We're going to nap. We're going to nappy nap. Okay, so I think we don't eat my pen. Okay, let's. Oh, okay, so this is all. He's helping me. Okay. Okay, so sorry, I am recording this. I know there's some messages that ACE, you guys are correct. AJ, can you have ACE? Say no, I'm sensitive to ACE. Can I have ACE? Say no ACE for me. No ACE for Mama's Billy. Okay, so he's like, what's going on? Okay, so sorry, I had to reboot my computer. Yes, he's getting so big. Yes, and if you're driving, you can listen. I am recording this. Just to remind everybody, I put in the discussion board points. I only have half of the homework entered. My teacheries crashed. Okay, yeah. AJ says, don't worry, the test will be fine. You guys got this, right? They got this, AJ. They're smart cookies. Oh boy, you're tooting. That's not good. So basically, I'm still entering the rest of the points. So don't panic if you see like there's something missing. As soon as I get done, I'm going to put in the rest of those this afternoon. So then that should all be entered. Now remember, your test will be open. I think I set it at 3:15. And then it should end tomorrow at 2:30. So you have like 24-hour window to take it. And once you end it, then it's going to be done, or you have 75 minutes. So the machine parts are going to be on there. That was not on the homework sheet, but the machine parts that we talked about, the breathing systems, knowing the weight ranges, the pressure manometer, the pop-off valve, and then remember we talked about rebreathing bags, how to calculate 30 mils per pound. Yeah, does it say 27 questions? And you know, there is a fair amount of essay questions, but some of them are just very short, you know, 2 and 3 words. And remember, I always put it on the essays, but if it's like a matching or like a fill in the blank, if you have to write the letter, not the word. Okay, so if it says A, propofol, you wouldn't write propofol, you would just write the letter A. So just make sure in those sections that you put the proper, you know, like a letter. Don't fill in the blank with anything. So just to review the machine stuff, the pressure manometer, remember that tells us the pressure in the system, and that, remember, should never go over 20 centimeters of water. So when you bag the patient, when you squeeze, it's going to go up to 20. When they're breathing on their own, it really shouldn't register much pressure, but it's right over the soda lime. And then the soda lime takes out the CO2. And then remember, I'm going to say, soda lime. The bag sizes, when you calculate it, you'll often get a very strange number. But remember, your bag sizes are in even sizes, and so you're always going to round up. So you're going to calculate what the volume that patient needs, but then you also have to put in, you know, then what is the bag size? And they are in whole sizes, so you want to make sure you choose the one so you have more room. And then remember 1 liter through 5 liters. And a half liter is a choice. Then we talked about, and then the endotracheal tube, remember, now that's part of the canine feline lectures. So if I go into your homework, one of the questions on your homework was, I have one pulled up here. So regarding intubation, you know, why do we intubate? You know, and a big reason is to decrease dead space, because that's non-functional gas exchange. So if you mask a patient down, they have to inhale gas through their nares, through the nasal passages, through the pharynx, the larynx. But if you intubate, gas goes right from the machine to the trachea. So you bypass all of those pieces of equipment. So it decreases dead space, it maintains an airway in case of emergencies. You fill up the cuff, and that prevents the leakage of gas. So if you're on a mask, you're going to get a lot of leakage out of the system. So this way, it's going to prevent that leakage, prevent aspiration. And one thing, if I did not stress in lecture, was when you fill up the cuff, it is not to hold the tube in place. Some people think that it helps the tube not slip. It should never be that tight. I have had to sometimes pull tubes in an emergency where I didn't have time to deflate the cuff, and you want to be able to pull that tube. So that's never an indicator, like you would never fill it up that tight, okay? So if I didn't stress that in lecture, well, yeah, Michaela, when you ventilate a patient, you only go to 20. To fill the cuff, you put air in the cuff till that's not measured in centimeters of water. You just put mils from a syringe and you fill the cuff till you don't hear a leak. So you inflate to 20 Yeah. So, but the 20 centimeters of water is when you are bagging the patient so that you don't go too high. Now, some downfalls to intubation, you know, we can have tracheal trauma. You can put it in the wrong spot. There is, you know, some things that can go wrong, but there's way more advantages to intubating than not intubating. So just be familiar with some of the pros and cons. One of the questions is, the other thing is you can manually ventilate your patient. If you don't have a tube in, like say you put a mask on a patient, if you squeeze the bag, it's just going to inflate their cheeks. It's not, maybe some will get down the trachea, but it's very hard to get to force air into the lungs. So another way is because you may want to ventilate the patient manually. So if you want to do that, you need to intubate. And then remember, vagal stimulation, that is also a downfall. If you're overzealous, that vagal nerve runs right with the trachea. You don't want to bump. Sometimes you hit the trachea, you bump that nerve. And then, remember, does anyone want to guess what happens when you vagally stimulate a patient? If you and you hit it, how would you, exactly. So your heart rate's going to plummet, which can also drop your blood pressure, but initially it's going to be bradycardia, and that's how you would know, because there's a lot of times you don't know you did it, and then all of a sudden you check your heart rate and your patient's heart, and heart rate's really, really low. But remember, if you're using an alpha 2, that could be why as well. But typically, if it was a hard intubation and then all of a sudden your patient's heart rate's low, it's probably maybe from being tubed. And remember, anatomy-wise, that was a question on the homework. You go over the epiglottis, through the vocal folds, which are attached to the larynx. That whole structure is the larynx. And then you go down into the trachea to the bifurcation. There was a question that I know was maybe kind of vague on the homework, but what do you do? It says, what do you do before turning a patient during anesthesia? Some people on the homework said, make sure the tube is secure, make sure the tube is in place. What I was looking for is, like, when you guys do a dental, yes, disconnect it. You disconnect the breathing system from the tube. So when you flip the patient, you don't twist the endotracheal tube. Okay, so you don't want to twist that in the trachea. So disconnect, then flip, then reconnect. On recovery, the steps to extubation. The first thing you do, you turn off your anesthetic, you turn off your ISO. We try to do 5 minutes of oxygen by itself. That helps flush the gas out of the system. That helps flush the gas out of the alveoli. And my other boxer's down here, so they're both by me. But you're going to flush everything out. So you do 5 minutes of oxygen. Then I deflate the cuff. And then I wait for the patient to swallow. And usually once they swallow 3 times, some people I said, what do you look for on recovery? And they said return of reflexes. Well, the main thing I'm looking for on extubation is swallowing. Now, sometimes I have a patient lift their head, blink, move their paws, and they don't even swallow. So just because they're blinking and moving their paws, you really want to see a swallow. If a patient can move their head, typically swallowing is very close, but you have to make sure that they can maintain an airway, which means that if there was aspiration, they have to be able to swallow and protect their airway. So that's why you're waiting to pull that tube. And then I said, what is the first thing we do after pulling the tube? Well, that was another thing that I talked about in the video. I said, when you pull the tube, you want to make sure your patient's respiratory rate or their respiratory effort don't change. Because if you pull their airway and then all of a sudden effort increases or the respiratory rate gets really rapid, you know, there's been a few times when I've had to re-anesthetize a patient and re-intubate them because they were having trouble breathing. Miss Wood, actually, when she was there, they went to check on a dog that recovered after an ultrasound procedure, and they found him dead in the cage, blue and dead. So he had recovered, kind of woke up, and this was maybe 20 minutes after the procedure, and they think he airway obstructed. So, you know, I sometimes stand there a good 5 minutes, but I see so many people pull the tube and walk away, and I just want to make sure that they can. I've also had sometimes patients, they'll get up and they'll shove their head in the corner, they'll turn upside down, and sometimes I try and fix them and they just lay that way. And if they do, they do, but you want to always make sure that they can breathe. So, snoring a little bit. I don't know if you can, baby snores. It's one fluid motion. Yes, so I pull it fairly quick, but it is one steady motion. One thing that it wasn't in the notes, but this is just my experience telling you guys. I've sometimes had patients wake up. Cats do this sometimes. This cat would literally chomp, would almost bite the tube in half and would not swallow. But we had to pull the tube because she was going to bite it. If they start chewing, the best thing to do is to hold their mouth shut. If you hold it shut, they can't bite their tube in half, and then get someone to help you. And then someone has to kind of hold the mouth open while the other one pulls the tube. So if that was to happen to you, I just say it's better to hold their mouth shut while they're chewing. And then sometimes I've had to yell for someone. I'm like, someone, someone, someone. And then I hold the mouth and someone yanks the tube. Are there any questions about intubation that I didn't maybe answer? Oh, there was also a question on the homework that I was a little bit vague on too, sorry, but it was, how long do we monitor temperature post-operatively? Usually you do it about every 5 to 15 minutes until they reach 99 degrees. Once a patient reaches 99 degrees, they should continue to go up and they should be able to maintain their own temperature. So after that, you can usually stop. And that's usually when we take the heating pad off. Because if you leave it on at 99 degrees, you can overheat them. So usually, I think in surgery, she has you monitor about every 5 minutes until they're 99 or 15. I said, what do we see in the patient to know they are progressing properly during recovery? So what you're starting to see, they're going from unconscious to conscious. So what you should start to see, return of reflexes, heart rate comes up, respiration comes up, awareness, like they can respond to their name. Maybe they start to wag their tail. Maybe they start to move. But if you extubate them and their heart rate starts to drop and they start to get pale and they're not breathing as often, then they're going the wrong way. They should be waking up, not going like, I mean, I've had patients fall asleep after I extubate them, but if I say their name, they respond. If I they should be more responsive and vital signs should be increasing. Can you hear him? I love the snores, I have to admit. I love when he snores. was a rough day. Although he's passing quite a bit of gas right now, so I'm kind of like, oh dear. And he already pooped in the dining room, so I'm not sure why. How do we help the patient recover? So one of the main things is, well, you heat them up. So we provide a warming blankets, talk to them, massage them, position them comfortably, give them padding. We usually cover them up with a blanket, but you continue to talk to them and rub them, and it should help bring them up. And then what is unique about brachycephalic recovery? Due to their compromised airway anatomy, we usually keep them intubated longer. I've had bulldogs standing, wagging their tail, looking at me with their tube in. So they can take quite a while to extubate. Oh, he got some gas. Holy moly. Okay. Let me go back up. You guys remember what give to effect is? A lot of people put, you give till, you see what you want. Like I said, it could take half the drug, quarter the drug, all the drug, but you start by giving it in those half increments till you achieve intubation or anesthesia. What are some key differences between IV and IM induction? So IV, it's quicker induction, quicker recovery. It doesn't last as long. IM is going to take a little bit longer to kick in, last longer. You can't titrate an IM induction. You're going to calculate a dose like Kitty Magic. You guys will calculate that for surgery. You give it all in the muscle. When I give propofol, I give like half and half and half. So you don't have a lot of control when you give IM. You give it and you hope it's enough, hope it's not too much, and then go from there. And then why do we pre-med? A lot of people, their go-to answer was to pre-treat for pain, which is good, preemptive analgesia, but it's also to calm the patient. It's much easier to put a catheter in when they're sedated versus, like this is what a good pre-med would look like. And I'm saying if I had to put an IV in him, I would want him like this, not like he was 10 minutes ago. So pre-meds, calming, sedation, anesthetic sparing is also a really good one. How long did Tiva and inhalants last? Okay, on the homework, which question was, let me go up. Oh, understand how long they last, how long they take effect. Okay, so when you give an IM induction, if you remember on that chart, there was like a, it was like a graph. IV induction, they're asleep right away. If you don't give anything else in about 10 minutes to 20 minutes, they're going to be awake. IM induction, it takes a little bit longer, okay? So it's going to take a little bit more to take effect. Now, Tiva, if you keep giving it, depending on how many agents or how many injections you give, Tiva, you're going to give a shot and wait. You're going to give a bolus and then you're going to wait. After you give the last bolus, in about 10 minutes, they're going to be awake. Now, if you do inhalants, when you turn off the inhalant, like an inhalant induction, in about 5 minutes, they're going to recover, 10 minutes. Does that make sense? So IV, it's going to, kick in very fast. Inhalant maintenance, they're going to recover in about 10 minutes. I'd say IM, it could be 30 to 40 minutes. after the injection. Okay. So that's kind of how I want you to compare. And then remember, Tiva, you're only using, instead of like giving propofol and putting a tube in and going on to ISO, that's IV induction. If you just do propofol, you can either just give some weight, some weight, some weight, or you continuously drip in propofol, which was the Tiva CRI. And that way, you're never like letting them get light and then redosing. You are getting them deep, and then you are keeping it dripped in continuously. And that way, they stay asleep. Like he could be on like a CRI right now. He's just like, you know. But when he woke up a little bit, I give a little bit, he goes back to sleep. So let me look at the other question. Oh, just what equipment? Intubation equipment, IV catheter equipment, drugs, oxygen. I know. He does, Michaela, when he lays like that, he's got his little puppy belly. Yeah, he's pretty funny. He definitely likes to sleep on people, which is just like how Bo was. So I talked about why to pre-med, why we give it to effect. How do we minimize adverse effects? You can pre-treat abnormalities, like give IV fluids, use certain pre-meds, double check, label, calculate, have people double check calculations, things like that. And then choosing, he heard somebody. Somebody's on. Okay. So when we choose, how do we choose the protocol? Now, choosing a protocol, it's going to kind of depend. Oh, you're Fari. You're Fari. Who is iPhone? I apologize, I'm late. I've been having issues all day. If you can just type your name. Oh, is that Ashlyn? Sorry. Okay. I just saw that. You're fine. So choosing a protocol and the dosage and the routes. So first of all, I look at, obviously the doctor is going to, tell you which protocol. But if I have an aggressive patient, I might go IM. If I have a geriatric patient, I'm going to use a light protocol. If I have a spastic boxer, I'm going to choose maybe a heavier protocol. So temperament, breed, procedure. If I only need a dog to sleep for like 10 minutes versus an hour, I'm going to choose different drugs. So what procedure am I doing? How old are they? Have they had any bad episodes before? Is the breed high risk? Does that make sense? That's what I'm trying to get at is if I've got all these drugs and all these protocols, how do I pick whether I go IV, whether I go IM? But I'm telling you, if I have a dog or a cat that's trying to kill me, I'm not going to sit there and place a catheter. And do you think it's going to let me mask it down? So maybe something IM. So that's what I was getting at with that thing. And then what types of things do we need to check to get them ready for anesthesia? So, a lot of this we talked about, it was like week 1 of anesthesia 1. A history. Do we check the blood work? Do we need to make any drug adjustments based on, patient has bad lab work, things like that. Were there any other questions from the homework that you have? or about the machines? Or anything you want to ask? So just to review, the test will go live here in 10, 12 minutes. You have till tomorrow at 2:30. This should not interfere with someone's class. So please, I don't want to hear from another teacher saying so-and-so wasn't in my class because they were taking your test. I took a risk to put this test open for an extended period of time so that it would not interfere with anybody's class. There would be no excuse for this to interfere. So I don't want to hear that from anybody. Please don't make us have a conversation. What are the cons of IV induction with Halen mates? Kirsten, there's not really a con to that. IV induction with inhalant maintenance is what you're going to do for your basic, like spay, neuter, dental, abdominal. Like that's the most common method of induction. The only con to that is you have to intubate. You could cause some tracheal irritation. It's generally associated with a longer recovery. So if you wanted to do something short, like cut some nails or take out some stitches, you probably wouldn't do all that. So that's really all I could say for the cons for that is the potential, intubation issues, or it's just a longer form of induction. Did that answer your question, hopefully? Okay. So just remember, plan wisely. I'm giving you a wide window. Don't make me regret it. It shouldn't interfere with anything. What we will do tomorrow, just to review, it'll be similar to this week. My Tuesday Zoom group, if you're Tuesday, you will report at 2:30 tomorrow. My goal is sometime tonight or tomorrow. I might do what I did where I recorded the lecture in like maybe 3 snippets. But I should have something for you to watch. We're going on to pain management and local anesthetics next. So I'll get all that kind of gathered. But if you're my Tuesday, some people have emailed me about notes. My goal is to put the notes in 112. I'm going to try to do it. I should be able to get it done in the morning. I don't know if I'll get it done before my 8 a.m. class, but I'd probably get it done in between. So sometime in the morning, there should be new notes in 112, somewhere on that back counter. I might try to put like a little Post-it note and point, because I know there were several handouts when I was in there the last time. Okay, so I'll have notes in there, and we'll start a new section. Yeah. So I can't think of anything else unless you guys have another question while you have me live. Me and the snoring box are live. Oh, the baby. No, we go. Okay. Go back to sleep. Okay, well, if you don't have anything else, I will let you go. He's pretty darn cute. I have to admit it. Oh, look at Caitlin's baby. Oh, see the puppy? We're holding our babies, Caitlin. Oh, all of a sudden he got a wild hair up his butt. Oh, there's a baby. See? Do you see the baby? Oh, the very sleepy box. This is nap time, typically for him. Go back to sleep. Oh. Well, AJ says good luck on the test. He says it'll be fine. He says, think about how would you anesthetize me, a crazy puppy. Look at that. Yeah, look at that pot belly, Michaela. I do look like a little pot belly pig. Oh, you lay like this? Oh. All right, I think I'm going to go put him on his little bed. Oh. You have a good day. I think I might go cuddle with a boxer. Take a nap. Take a nap. He says, bye, good luck. He goes, you got this. Yes, a nap looks like a great plan.